Hi guys, this is going to be part 3 of our series on acute coronary syndrome, and here we're going to talk about how to treat acute coronary syndrome. How to treat someone with ACS. So you've already gone through your 3 questions to diagnose ACS. You've decided, okay, I think the patient is having acute coronary syndrome. What do you do now? The way that I like to think about this is that the treatment for ACS basically involves 2 different complementary things. One is medicines, and the other is reperfusion. Now, when we talk about medicines, most of the medicines for treating ACS are intended to target the thrombosis pathway. Because remember, the vast majority of ACS is due to plaque rupture and acute vessel thrombosis. In this little talk, we're not going to talk much about etiologies of ACS that are not due to plaque rupture, such as dissection or vasospasm. There are other things, but we're going to focus mostly on the treatment of sort of standard plaque rupture mediated acute coronary syndrome. The medicines that are going to be important to know and important to use: aspirin, an anticoagulant, and we'll come back to the choice of which one in a minute, beta blocker, and again we'll come back to the choice of which one in a minute, statin, and some sort of second antiplatelet agent. You guys have probably also heard about the use of oxygen or the use of opioids or the use of nitrates, and we'll discuss each of these in turn. When it comes to aspirin, usually if they're not already on aspirin, we'll give them a single dose of 325 milligrams chewable. If they're already on aspirin, probably you can get away with just continuing their 81 milligrams daily, just like they would normally get. As far as an anticoagulant, most of the time people will be given, if they're not already on an anticoagulant, they'll be given some sort of heparin product. Frequently it's IV heparin, which allows us to turn it on and off if they're going to go to the cath lab or something like that. You can give low molecular weight heparin subcutaneously. We tend not to do that as much here, but it's definitely something that is done. Beta blocker, usually if they're not already on one, people are giving metoprolol. Statins, ideally here should be a high intensity statin, and so this is going to be something like atorvastatin 80 milligrams or rosuvastatin 40 milligrams. And when it comes to the second antiplatelet agent, the choices are basically using a P2Y12 inhibitor, which is going to be clopidogrel, ticagrelor, or prasugrel. These are all slightly different. They all have there's subtleties to them that we may discuss in a future video. The other thing that sometimes gets used in the cath lab is a glycoprotein 2B3A inhibitor, and that's going to be something like eptifibatide or abciximab. You might see these used in the cath lab. So all of these medicines, aspirin, anticoagulation, beta blocker, statin, and second antiplatelet agent, all of these ones on the left side of this line improve outcomes in people with ACS. The medicines on the right side of this line, or the treatments on the right side of this line, have not been shown to improve outcomes. And I'll talk about each of these a little more specifically. Oxygen is an interesting one. If the patient is hypoxic, oxygen is definitely useful, but really only if the patient is hypoxic. There's some data for patients who are not hypoxic that it may actually cause some worsening free radical damage. So only if patients are hypoxic. Opioids, they do help people with their pain, but my personal approach is to use them sort of sparingly or not at all. And I'll explain why as we get further along. Nitrates, the common one that people use is nitroglycerin. And the good thing about nitroglycerin is that you can give it sublingual or you can give it IV. Sublingual, the dose is usually 400 micrograms up to 3 doses, and IV, the dose is somewhere between 0 and 400 micrograms per minute. A common approach people use is giving a few doses of sublingual nitro as a loading dose and then starting someone on an IV infusion. All right, so once you've decided that somebody has ACS or that you're going to treat them for ACS, everybody should be given all of these medicines on the left side of this line, all 5 that are known to improve outcomes. A common management strategy I've seen people use is to give people only some of these medicines depending on your certainty of whether or not they have ACS. Personally, I don't think that's the right approach. Personally, I think that you should make your decision about whether you think they have ACS. You should, go through the algorithm from the last video about diagnosing them with ACS, and once you've decided they have it, everyone should be given all of these medicines unless they have a clear contraindication. Speaking of which, contraindications to these medicines, anaphylactic allergy to any of them, obviously. Contraindications to anticoagulants are basically severe bleeding, but especially intracranial bleeding. That's also sort of obvious. Beta blockers, contraindications are going to be shock or significant bradycardia. That's really the only major contraindications for these group of 5 medicines over here. One other point to make about the second antiplatelet agent is that sometimes we'll hold off on giving these agents until we know a patient is or is not going for bypass surgery. That's a slightly more complicated topic that we can talk about in a separate video. So once you've given your medicines to treat people for ACS, the second issue to treat them is reperfusion. In general, there's 2 ways to reperfuse people. The first is with lytics, with thrombolytic therapy. Thrombolytics are the older form of reperfusion. They work, but they tend to work less well and have more side effects than mechanical reperfusion in the cath lab. So it's almost never the case that someone gets only thrombolytics, and in fact, there's data showing that PCI with placement of a stent is superior to thrombolytics. And so in most resource-rich environments in the United States, thrombolytics are not the reperfusion of choice. What is the reperfusion of choice is going to the cath lab for percutaneous coronary intervention, or PCI. The details of those procedures are beyond the scope of this talk. What I'll talk about instead is how quickly do you need to reperfuse somebody? And basically the way I think about it is people fit into 3 categories. Category number 1 is people who are having a STEMI. And the answer for how quickly you need to send them to the cath lab is right now. As fast as possible. Time is muscle. The longer you wait, the more tissue will die. There's door-to-balloon time metrics and this and that apply to the hospital as a whole, but in general, for the patient in front of you, you want them in the lab as soon as possible. If someone is not having a STEMI, so that means they're either having an NSTEMI or unstable angina, then the next question I like to ask myself is, are they dying of their ACS or not? It's a little bit crass, but what I mean by that is, are they having a complication of their acute coronary syndrome that is rapidly life-threatening? And the complications that we're talking about here are ventricular arrhythmias, VT, VF, respiratory failure, shock, cardiogenic shock, or complete heart block. Any one of these things that are acutely and rapidly life-threatening. If any of those is present, then really they should also go to the cath lab right now. Even though it's not a STEMI, even though it's not a total occlusion of one of their arteries, it's very clear that they're not handling it and they need to be treated immediately. If none of those things are present, then you've decided, then the question becomes, how high risk are they? And the way that in general it works is you sort of split people into higher risk or lower risk. And the people who are higher risk should probably go soon, maybe 24 to 48 hours. And the people who are lower risk should probably go less soon, maybe 48 to 96 hours, something like that. How do we decide who's high risk and who's low risk in this particular group? There's a couple of risk scores that you might have heard about that'll let you assess the risk. There's the TIMI score, there's the GRACE score. The details of those are beyond the scope of this talk, but that's how that will help us decide. One final point to make is, let's suppose you have stratified somebody into this group and you're waiting for the time of their procedure and they develop what's called refractory ischemia. Refractory ischemia is where, despite all the nitrates and all the medical treatment you've given them, they continue to have chest pain and you cannot get them pain-free. In those cases, it's an indicator that infarction is ongoing despite your medical therapy. They're failing medical therapy, and those people should probably also go now. This is the reason why I tend not to use a lot of opiates or opioids, because I like to know when people are having refractory ischemia, and often patients who are given a lot of opioids will be sort of sedated, and so they will be less able to communicate about their chest pain. So for this particular reason, I really don't like to give a lot of opioids. All right, so just to summarize, once we've decided someone has ACS, how do we treat it? Well, first we give them medicines. There's this group of 5 medicines that we give to everybody with ACS unless there's an active contraindication, and that's aspirin, an anticoagulant, usually IV heparin, a beta blocker, usually metoprolol, a high-intensity statin, and a second antiplatelet agent. If they're having chest pain, you can give them nitrates. If they're hypoxic, you give them oxygen. Try to avoid opiates when possible. And then the second question is, you should be thinking about the patient needs reperfusion. How soon do we reperfuse them? Well, ideally, you take them to the cath lab if you have a cath lab around. And if they're having a STEMI, you go as fast as possible. If they're not having a STEMI, then you assess for, are they dying right now or not? If they are, then you take them as fast as possible. If they're not, then you think about their overall risk using one of the scores like a TIMI score or a GRACE score. The higher risk, the sooner they go. The lower risk, the less soon they go. And if they at any point develop refractory ischemia, then that will bump them up and make you revascularize them a little bit sooner. All right, thank you guys. That was the end of our series on ACS. Hopefully this has been helpful.